Now that we are starting retinal pathologies, everybody, that is where the difficulty usually comes. There are so many conditions that are given in our books, everybody, that again, as I said in the beginning, we actually don't read them. And that is how what I'm trying to make easy for you. To make it easy, I divide retinal pathologies into various groups. The first is the intraocular tumor, retinoblastoma. The second are a group of disorders which affect the macula, macular disorders. As in when we read them, we will realize there are a lot of commonalities between all the macular disorders, because all of them at last are affecting the macula, so they will lead to loss of central vision, and the treatments and everything will be a lot close. So that is why we are able to remember 3 or 4 diseases as one single group, and it becomes easier to segment into our brains, everybody. The third group is dystrophies of the fundus. As we will read, these dystrophies are based on basically 2 words, either problems of rod cell or problems of cone cell. So again, we are able to learn a lot of diseases just based in one group based on 2 words, a lot of commonalities. Next will be vascular group of disorders. This is usually the disorder group that a lot of us don't study, or if we study, we don't understand, but it is very easy again if we understand the commonalities of vessels, of what is leakage, of what is blockage, everybody. And lastly, we will read retinal detachment. So as soon as I divide retinal pathologies into 5 groups, I am actually not reading one chapter, I am reading 5 small chapters, and I feel like reading them. And that is what we are going to do. We are going to first of all start with our first chapter, everybody, or first part of retinal pathologies, that is retinoblastoma. What is retinoblastoma and why are lots of questions asked on this? Because this is the most common primary intraocular malignancy. Because this is the most common primary intraocular malignancy, everybody, whenever you ask me to ask you a question on any ocular tumor, the first word, the only probably word that comes into my mind is retinoblastoma. It has an incidence of almost 1 in 17,000 new births, everybody. Yes? Now, let's move on to the etiology or the transmission of retinoblastoma. Just like any other tumor or any other disease, it can be non-hereditary or it can be inherited, hereditary. Now, which is more common, non-hereditary or hereditary? Non-hereditary is more common at 60% cases, whereas hereditary is less common at 40% cases. Okay? When we hear the word hereditary, everybody, usually we think that we are talking about the fact that our parents also had retinoblastoma in this case, and we will also have retinoblastoma. So that means when we hear the word hereditary, we usually think we are talking about family history. That is where we are wrong. Hereditary only means inherited. Your parents may or may not have the disease, but they have given you the disease, they have passed on the genes. That is why I further divide hereditary into 2 groups. Non-familial and familial. Familial is the only group where I say family history is present. Familial forms only 7 to 10% of total cases, whereas non-familial is 30 to 33% of total cases. If I combine non-hereditary and non-familial, I get the word sporadic, because these cases are occurring due to a new mutation. So almost 90% of my cases are occurring due to a new mutation, everybody. So if somebody asks you what is the most common, everybody, actually it is not even non-hereditary. If the option is given as sporadic, you will always mark sporadic here. Yes? Now, please remember, non-hereditary cases, they are always unilateral in cases of retinoblastoma, whereas hereditary cases can be unilateral or they can be bilateral. Am I making sense? Very simple, clear everybody? Yes? Now we understand this. Let us talk a little bit about hereditary retinoblastoma. Hereditary retinoblastoma. First of all, everybody, what is the mode of inheritance? So the mode of inheritance in hereditary retinoblastoma is autosomal dominant. Then everybody, what is the gene? The gene is RB1 gene. Okay, retinoblastoma 1, RB1 gene. RB1 gene, if you know your pathology well, you know that this is a tumor suppressor gene. Where is RB1 gene located? 13q14. Yes or no? 13q14. Very easy to remember, everybody. So that is the basics of our genetics. Also remember that hereditary retinoblastoma follows a very important concept that is known as Knudsen's or Knudson's two-hit hypothesis. What does this Knudson's two-hit hypothesis mean and what does it tell us? Everybody, in very simple words, we say that every chromosome has two alleles and thus two copies of the gene. We are saying the first mutation, everybody, the first mutation the patient is inheriting. Hereditary retinoblastoma, yes or no? So the patient is inheriting the first mutation, everybody. So before birth, the patient has the first mutation, which is enough to be able to start the pathogenesis of the tumor, everybody. So I am saying genotypically, the tumor is autosomal dominant. But another mutation is needed on the second allele, everybody. Second mutation is needed and this occurs after birth, everybody. This occurs after birth. So the second mutation is acquired and only after the second mutation occurs, everybody, or the second hit occurs, that is when clinically the tumor starts to present, everybody. So I say phenotypically my tumor is what, everybody? Phenotypically my tumor is autosomal recessive. So Knudson's two-hit hypothesis is telling us that it is only after the second mutation or the second hit, everybody, that the clinical presentation will start, and there are two mutations occurring at two different points of time, everybody. So based on Knudson's two-hit hypothesis, again I say genotypically, everybody, we are autosomal dominant, but phenotypically we have autosomal recessive. Or if we say in simple English, Knudson's two-hit hypothesis states that loss of heterozygosity leads to malignant transformation and presentation. Okay, everybody? So second hit leads to loss of heterozygosity, and that is what makes it phenotypically presentable, everybody. That is Knudson's two-hit hypothesis. Are we clear about this? Okay. Now, moving on, everybody. A question is very commonly asked: what is the most common associated malignancy? Yes? Usually the answer you will find written in a lot of places is osteosarcoma. That is an absolutely wrong answer. The correct answer here is pinealoblastoma, or we can say primitive neuroendocrinal tumor, PNET. Primitive neuroendocrinal tumor. Okay, everybody? It is so common, everybody, that bilateral retinoblastoma plus pinealoblastoma is known as trilateral retinoblastoma. So it is almost always considered that if you have retinoblastoma, you will end up having pinealoblastoma. So this is considered a third part of retinoblastoma, everybody. Yes? Now, if the question is slightly asked in a different way, what is the most common associated secondary malignancy? If they're asking you most common associated secondary malignancy, that is when you end up answering osteosarcoma. So osteosarcoma is occurred due to metastasis from the primary tumor, everybody. It is the secondary malignancy. But the most common associated malignancy, even without any metastasis occurring, is pinealoblastoma. I hope you understand the two questions here about the hereditary retinoblastoma, which usually you may get wrong here, everybody. Yes? And that's the basic part of our etiology or transmission modes of retinoblastoma. So now let us move on to the clinical features or the presentation of a case of retinoblastoma. Number one, what is the most common sign, everybody? So the most common sign, everybody, that the patient presents with or the child presents with is leukocoria. Leukocoria. Now, I hope you have heard this word. If not, everybody, this is a simple English word, everybody. I can break this down into two, everybody. Leuko and choria. Leukocytes, everybody. Leuko means white. Choria, everybody, if you have read neuro-ophthalmology, isochoria and isochoria. So choria means pupil. So leukochoria basically tells you that there is white pupil. But when I write white pupil, it sounds funny. Why does it sound funny, everybody? Because we know that pupil is not a structure, everybody. Pupil is just an aperture. It is the whole or the central part of the iris. So how can a structure which does not exist become white in color? So I rather say white pupillary reflex. What do I mean to say? Pupillary reflex. So we say normally in loose language that the normal color of the pupil is black. Why do we say the normal color of the pupil is black? We are not talking about the color of the pupil. We are saying that when we look at the pupil, it appears black. Why, everybody? Because all the structures posterior to the pupil are transparent. Yes or no, everybody? If I draw a rough diagram here again, everybody, this is my cornea, iris and lens. This is my pupil, everybody. Yes? Behind the pupil, what do we have? We have posterior chamber containing aqueous transparent, lens transparent, large vitreous transparent. So when we are looking through the pupil, we are looking at an empty cavity which is absolutely transparent, and that is why it appears black. So when we are saying we have leukocoria, does that mean my pupil has become white? No, everybody, I hope you understand. We are trying to say that the pupil is appearing white because some structure behind the pupil must have become white. So let's say I have cataract, everybody. If I have cataract white in color, everybody, mature cortical cataract. If my cataract is white, everybody, my pupil will again be appearing white in color, white pupillary reflex. If I have some pathology in the vitreous, everybody, we have read endophthalmitis, a complication of cataract surgery. Endophthalmitis presents with whitish or yellowish exudates in the vitreous. So again, my pupil will be giving a white color reflex, everybody, because a structure behind the pupil is white. Or in this case, there is retinoblastoma, a tumor, everybody. This tumor is calcified. This is white in color. So when I look at the pupil, I see a white reflection coming from posterior to it, everybody. I hope we are clear that pupil cannot become white. When we are saying leukocoria, we are saying a structure posterior to the pupil has become white. That means leukocoria is a sign which can have various diagnoses. That means when I look at this photograph, everybody, what is my diagnosis? My diagnosis is that the right eye is normal. The pupil is appearing black. But in left eye, my pupil is appearing whitish, yellowish. So my diagnosis is simply leukocoria. I cannot be sure just by looking at such a photograph of leukocoria whether it is retinoblastoma. It can be a case of cataract also. Am I clear to everybody? Let's suppose you have not read retina, you have not heard the word leukocoria till now. If I show you this photograph, can you assume that the lens may be opacified, that it may be a cataract? I hope I'm getting the message across. But still, I will say in this case, it is a case of retinoblastoma. Why, everybody? That's what I'm writing here. Most common cause of unilateral leukocoria is retinoblastoma, whereas the most common cause of bilateral leukocoria is usually cataract. Okay, everybody? I hope we are pretty clear. Also remember that the image was of a child. Retinoblastoma most commonly presents in less than 3 years of age. So the fact that the image again show you everybody is of a child, everybody, and we have a unilateral leukocoria along with the other signs that we will just discuss should be enough to able to help us diagnose a case of or differential diagnosis number 1, retinoblastoma here, everybody. Yes or no? Done? Now, this is the first most common sign. Now, everybody, second most common sign of retinoblastoma is squint. Usually presents as esotropia. It can present with exotropia also, but usually presents as esotropia. Number 3, third most common sign is secondary glaucoma with buophthalmos. Secondary glaucoma occurring due to seeding from a tumor, everybody. There is another cause. And why with buophthalmos, everybody? Because we know congenital glaucoma also occurs less than 3 years of age. And when congenital glaucoma occurs, a very important sign is enlarged eyeball buophthalmos. So because retinoblastoma is causing glaucoma in a child at less than 3 years of age, we know that the eyeball will be enlarged in such a case also. Yes, these are the 3 most common signs, everybody. Can there be more signs? Yes, there can be thousands of signs, everybody. As the tumor grows, it invades various other structures. Whichever structure it will invade, it will present with a presentation. It invades iris, there will be some kind of iritis. It invades lens, some kind of cataract will form. So we cannot write a whole list. If we write a whole list here, we will actually end up studying the whole ophthalmology. So for here, the 3 most common signs. Now, apart from this, everybody, when we're talking about the clinical features of a tumor, we should ask ourselves, what is the most common route of spread? Yes, metastasis. So the tumor will metastasize. What can be the routes of metastasis? Yes, very good, all of us know. Number 1, it can be through blood, hematogenous. Number 2, it can be through lymph, lymphatic. Or lastly, it can be through the tissue itself, in this case the ocular tissue, and that is when we say the route of spread is direct. So the question is, out of this, which is the most common route of spread? The answer is direct spread. Okay, everybody? Now, direct spread means through the ocular tissue itself. So through which ocular tissue, everybody? Through either optic nerve, most commonly, or through sclera. Am I making myself very clear here, everybody? So the most common route of spread is direct, and direct spread most commonly occurs through optic nerve. Again, hear my voice. The most common route of spread is direct, and the direct spread most commonly occurs through optic nerve. So everybody, if I ask you a question, simple MCQ comes in your exam. What is the most common route of spread of retinoblastoma? Option A, hematogenous. Option B, lymphatic. Option C, direct. Option D, optic nerve. Will you mark direct or optic nerve, everybody? You will mark optic nerve? No, na? Yes, I know. You will mark direct. You are smart. Again, I'm saying for the last time, the most common route of spread is direct. But if they ask you the most common spread occurs through, then the answer is optic nerve. Okay, so please read the language of the question carefully and then only answer this question. Yes. Now let us see a photograph of retinoblastoma now that we've seen the clinical features, everybody. Let us see this photograph. We are able to see the optic disc, we are able to see the blood vessels, but along with that we are able to see a tumor growing inside everybody. Yes, so this denotes a growth pattern which is endophytic. I hope you understand. Endophytic means from the retina, the tumor is growing into vitreous. Okay? We are able to see an elevated mass going inside the vitreous. But it could have been the other way around. It could have been exophytic. Exophytic means grows towards exo, outside. What is outside the retina, everybody? Outside the retina is choroid, yes. Or the third pattern may be retrolaminar. This has the worst prognosis or the most dangerous, everybody, because retrolaminar means it is traveling via optic nerve into the orbit and the cortex or the cranium, can I say? Yes or no? Retrolaminar, it is passing the laminar plate, everybody, the scleral holes, and it is going outside, everybody. Laminar plate, everybody, of the sclera, I hope you remember, everybody. Yes, that offers the maximum resistance, everybody, for its growth. So if it is passing that retrolaminar, it is going outside the eye, everybody, then it has the worst prognosis, because then we know it is going to lead to intracranial metastasis and other metastases, everybody. I hope we understand the growths of pattern here. Yes. Now that we know the clinical features, everybody, let us confirm. Confirm means we need to do some investigations. So investigations. Number 1, investigation of choice. Investigation of choice, at a lot of places you will find written MRI. But as I've always taught, as I've always said, the investigation of choice in a country like India is X-ray or CT scan. MRI is not available in almost 70% of our population, which still lives in rural India. An investigation of choice should obviously be able to diagnose everybody, but it should also be accessible and available to all. Yes or no? X-rays and CT scans are usually available. Now, why can X-ray or CT scan be done as the investigation of choice? As retinoblastoma is the most common cause of intraocular calcification. So we know that we have retinoblastoma, it is a calcified tumor. Calcification can be seen both on an X-ray and on a CT scan. Out of the two, which is better? Obviously CT scan, everybody. Yes. Also remember that CT scan can detect intracranial metastasis. Do you understand what I'm trying to say here, everybody? Yes. So even to a certain extent, metastasis will be able to get detected. Diagnosis as well as metastasis. Should MRI be done? If available, obviously it should be done, because it can assess extraocular and extracranial metastasis. Obviously it should be done, but maybe not the investigation of choice as I am trying to explain to you here. Please. Yes. Number 3, there are increased levels of LDH. What is LDH? Lactate dehydrogenase in aqueous, due to the excessive metabolism by the tissue mass of everybody. Yes. So because the tissue mass is growing, the metabolism is increasing, there is increased levels of LDH. Lastly, everybody, if I ask you, what is the gold standard investigation? then I hope you understand we are talking about a tumor here, so we need to confirm. So the gold standard has to always be biopsy. Okay, everybody. Now, this biopsy can be of two types. Either I can go in everybody incisional biopsy or excisional biopsy. Okay, incisional biopsy means I go in, I take a part of the tumor, I do histopathology and I confirm. Excisional means we are kind of almost always confirmed. We have removed the whole tumor, everybody, and then we are doing the biopsy. Here, which biopsy is done, everybody? Excisional biopsy. Sample for biopsy is taken from optic nerve. The sample for biopsy is taken from optic nerve, and after we take the sample, everybody, we do histopathology. Why are we using optic nerve, everybody? Because we know that the most common spread occurs through optic nerve. So now comes the question, what are the histopathologic features? I hope you know these names. If not, everybody, these are very fancy names. Flexner, Wintersteiner, Rosettes. You don't remember Flexner, Wintersteiner, that will do, but don't forget Rosettes, everybody. In pathology also we are taught this, Rosettes, everybody, Flexner, Wintersteiner, Rosettes. The second is, everybody, Homer, Wright, Rosettes, which are also known as pseudo Rosettes. They are not true Rosettes, they just look like Rosettes, everybody. And then the third feature is known as fleurettes, everybody. Okay, pathognomic or diagnostic is Flexner, Wintersteiner, Rosettes. Okay, you remember the names? You don't, at least remember, again I am saying Rosettes here, everybody. Yes, please remember, Homer, Wright, Rosettes are also seen in neuroblastoma, Ewing's sarcoma. That's why I'm saying the pathognomic are Flexner, Wintersteiner, not any others. Okay. Now, you should be able to identify these in a photograph, everybody. Obviously, with the clinical scenarios becoming important, you may be given a history. Then you may be it may be said that on biopsy, the following image is seen, everybody. The following image is seen. What is your diagnosis? So what can we see in this image, everybody? Can we see a rosette, everybody? Yes, we can see a beautiful rosette. Look at this, everybody. We can see a beautiful rosette. What is a rosette, everybody? A rosette has a central empty lumen. Yes, with the cells arranged outside. Cells arranged outside. Nuclei away from lumen. Okay, so I hope we can see a complete central empty lumen. These are all the cells, and the nuclei are situated on the outside, away from the central lumen. So this is my lumen, this is my cell, like a rosette, everybody. I hope you can understand, a collection of flower or a flower, everybody. Yes, and the nuclei are located away from the lumen. So roughly this is how my Flexner, Wintersteiner rosettes look like. True rosettes, everybody. Yes or no? I hope we are clear. Now, if we see another photograph, everybody, can we see, everybody? This photograph. These structures, everybody, they look as if they are rosettes, but are they rosettes? No. There is no central empty lumen. This is just a central entangle of neural processes. I hope you cannot see any empty area in the white center here, everybody. Yes, whereas in that case we were able to see a central empty lumen. Let's see again, everybody. You will be clearly able to see a central empty lumen. I hope you understand the difference between this. Yes, whereas in this case there is no central empty lumen. All this area, everybody, is filled with entanglement of neural processes, and there are irregularly arranged cells. The nuclei are not necessarily pointing away from the lumen. There is no lumen, nuclei are not arranged, just trying to give the appearance, everybody. They are pseudo rosettes or Homer-Wright rosettes. Okay, everybody, here both the images I hope we are clear about. Now let us see another image, everybody, an MRI image, everybody. In this MRI image, can you make out that it is a case of retinoblastoma? I hope we can, everybody. We can see the cornea, we can see a little bit of iris tissue. Then when we move on to the retina, we see that there is an endophytic mass growing, everybody. That means it is a case of retinoblastoma, along with all the other things that we know, the clinical features that we see when we do such an investigation. We know that we are talking about retinoblastoma. I hope we are clear about this, everybody. Yes. So now that we have been able to see the clinical features, we have been able to investigate and confirm our diagnosis, let us understand what is the treatment of retinoblastoma. So I say number one, if a simple question is asked to you, what is the treatment of choice for retinoblastoma? What will you say? Treatment of choice. The treatment of choice will be this word, enucleation. What is enucleation, everybody? What is enucleation? Yes, enucleation is removal of whole eyeball along with what, everybody? Along with what, everybody? Yes, along with optic nerve. By now you understand that optic nerve needs to be removed, yes or no? So removal of the whole eyeball, complete eyeball along with optic nerve, that is enucleation, and that is the treatment of choice. Okay, but what are the other options we have? The other option we have is chemotherapy. When we do chemotherapy, everybody, there are 3 drugs available to us. We can remember as CEV. What is C, everybody? C is carboplatin, E for etoposide, and V for vincristine. CEV. See, that is where the examiners are smart. Examiners know that a lot of students, when they are revising, they will not go through the whole names, they will remember only CEV. And that is why a question was asked, everybody, 2 years back. In that, there were 2 options, carboplatin, etoposide, vincristine. But there was another option, cyclophosphamide, etoposide, vincristine. Now, people who had not paid attention to what is C, what is E, what is V, they had 2 options with CEV. So as I always say, when we are reading, it is important to read everything carefully, because the question may not be tough, but the options are designed in such a way to separate the average from the below average, everybody. Yes. So we know that such simple stuff will be able to differentiate between the people who have actually devoted time to a subject rather than people who have been superficial. I don't want us to be superficial. I want us to be thorough here, everybody. Yes. Now, so we have 2 options here, everybody. As we said, either we can do enucleation or we can do chemotherapy. If the question is asked in a little detail based on staging, okay. So let's say they ask you what is the grade 1, grade 2, grade 3, grade 4, grade 5. So they are asking you what is the treatment option when we have grade 1 tumor. So in grade 1 tumor, we can do things like cryotherapy, or we can do laser photocoagulation. Okay. Usually we don't do anything. In grade 2, we have to resort to chemotherapy, and we give up 2 drugs, C and V, only 2 drugs. In grade 3 and grade 4, again we prefer chemotherapy, and we give all the 3 drugs, C, E, V. Whereas in grade 5, we have no other option but to do enucleation. See, we are trying to avoid enucleation as long as possible. When we are doing enucleation, we are actually making the patient blind. We are taking out the eye. Yes, as an ophthalmologist, I want to save the eye, but we can save the eye only to a certain extent. If we have grade 5 means everybody, tumor occupies greater than 50% of eyeball volume. The child is already blind, everybody, and it is going to metastasize. It is metastasizing. We need to think about that. Or if there is vitreous hemorrhage, or if there is rubeosis iridis, neovascularization of the iris. If you don't know about this, everybody, we will read it in a little while in our vascular disorders of the retina. If any of the three conditions persist, we call it grade 5 and we have no other option but to enucleate. Chemotherapy will not be useful in such a case. And that's all about the treatment of retinoblastoma. That's all about retinoblastoma as a topic. As I said in the beginning, this is probably the single most important topic in retina because that is the only tumor that I'll end up teaching you, everybody. Questions are asked each and every year from retinoblastoma, but it is very easy, everybody. We need to just think about in a sequential way. What is the transmission? What is the hereditary? In hereditary, we need to remember a phenomenon known as Knudsen's-Tuit hypothesis. Clinical features, leukocoria. Remember that pupil is not white. It is the structures behind the pupil which are white. Investigations, gold standard, histopathology, and then the treatment options. Very easy to remember. Some 10-15 questions can come from it, and those are the questions that come from it, along with all the images that I have shown you here, everybody.
Now we start with the second pathology, group of disorder, that is macular disorders. Macular disorders, as soon as I hear this name, the first thing that comes into my mind is central vision getting lost. Macula and fovea are responsible for central vision. So I hope you understand that whenever a patient has a macular disorder, because the central vision gets affected, the patient presents to us promptly. And the diagnosis also needs to be prompt likewise. Why? Because if we leave the pathology for a long time, some chronic damage can occur at the macula. And once chronic damage occurs, central vision will be lost permanently. The patient will lose the vision permanently. I hope you understand this. So this group is an important group of disorders from the point of diagnosis as well as from the point of view of treatment. So there is a set of tests which we specifically call as macular function tests. Macular function tests. These macular function tests can be divided into two groups done when there is clear ocular media. That means there is no opacity in the cornea or in the lens. And if there is hazy media. Okay? If there is an opacity, either a corneal opacity or a cataract. Okay? What are the tests done, everybody? For clear media, we can do first of all visual acuity measurement. Simply we are recording the vision. If the central vision is lost, the vision will be less on Snellen's chart. Yes. Secondly, we can do FFA. Thirdly, we can do OCT. FFA we have seen already that there will be leakage at the macula. FFA, OCT, it will show us the problem in the layer, everybody, which is affected at the macula. Fourthly, we can do a test which is known as photo stress test. The question was asked in NEET 2020 on this. The question was very simple. All you needed to remember was the name from this list. The question was, photo stress test is used for. The answer was differentiation between macula and optic nerve disease. Okay, everybody? Only one option mentioned macula. That was the ease of the question. But you needed to remember. What do we do in this test actually? We shine light on retina for 10 seconds. Okay? Then we record time of recovery of vision to within one line of pre-test vision. You understand? If the pre-test vision was 6 by 12, within one line means 6 by 18, okay, on Snellen's chart. If this time everybody is normal, then we say optic nerve disease. If this time taken is delayed, then we say this is a macular disease. Am I clear to everybody? Because the light is shining at the macula. If there is a macular disease, it will take more time for the cells to start functioning back. That's all. As simple as that. Photo stress test. Okay. Now, number 5. The 5th test is Amsler's grid. This is actually the most commonly done macular function test. Okay. Amsler's grid. So let's see in a little detail what is Amsler's grid. Everybody. Amsler's grid. This is what an Amsler's grid looks like. I've already pointed it out in squint, everybody. It looks like a Hess chart, but Hess chart has concave lines. So Amsler's grid is basically a square chart which has 400 5 into 5 mm squares. Okay, everybody? This can be either a digital or it can be printed on a piece of paper. Okay, done. You ask the patient to fixate at the central dot, everybody. Look at this photograph. You ask the patient to look at the central dot and then see what is surrounding that. A normal person will say, I see lot of straight lines forming squares. But if the patient had a macular disease, then this is what the patient would have seen, as seen in the second image. Okay, everybody, image number B. The patient would have said, I see some lines, yes. But some of the lines seem as if they are going inside the paper. Some of the lines seem as if they are coming out. Something is going in, something is coming out. Something is going in, something is coming out. So the patient is saying that I see wavy lines. Wavy lines are diagnostic of macular disease. Due to the swelling of the macular disease, the contour of the retina has changed, and that is why the contour of the lines is perceived to be different. In advanced cases, you won't even need to do this test. The patient will come to me and say, sir, the wall in front of you is plain straight to you. But when I look at that wall, I feel as if the wall is in the form of waves. Somebody has made waves on the wall. Okay, everybody? Done? As simple as that. The third patient can see something like this. Missing lines. The patient will say that a part of the lines are missing. This denotes optic nerve disease. So in effect, if you ask me, Amsler's grid is also like photo stress test in the fact that it can differentiate between macular disease and optic nerve disease. Am I crystal clear to everybody? Yes, but very seldom done for optic nerve disease diagnosis, mainly done for the diagnosis of macular disorders, wavy lines. Please see Amsler's grid. All these image-based questions can be asked to you. These are all the tests for clear media. What about the test in hazy media? In hazy media, everybody, the test we can do is Maddox rod test, already explained in squint lecture. Number 2, everybody, as we have just now noted a little while back, multifocal ERG, because it is producing responses only from cone cells, everybody. It can be used as a macular function test. Number 3, we can do something called as Lee and Palm. Lee is called as laser interferometry, and Palm is potential acuity meter. Number 5, everybody. The 5th important test that we can do in this case is called as entoptic phenomena. Okay, guys, just remember these names. Not done very commonly, everybody, but you have to remember these names at least. Okay, we can do a multifocal ERG, Lee, Palm, everything, guys, right? So these are our macular function tests. Now, once we have done a macular function test, we know that the macula has a disease. What disease does the macula have? That's the next question that begs our attention. So now we are going to discuss macular disorders or macular diseases. Okay. The first 2 macular disorders that we will discuss will be in a comparative format in comparison to each other. So the first macular disorder which I am discussing is CSR, and the second macular disorder is CME. Okay, everybody? CSR, CME. Let's say the full forms first. CSR, central serous retinopathy, central serous retinopathy, and CME is cystoid macular edema. Cystoid macular edema. Focus on the name. Let's understand what is the commonality between the two. Central means macula, yes or no? Serous means some kind of a fluid. So I am saying some kind of a serous fluid is accumulating at the macula, accumulation of fluid at macula, okay? Similarly, if I look at the other name, cystoid macular edema, macular means macula, edema means collection of fluid. So both the names are telling you that there is collection of fluid at the macula. You understand why we are discussing them in comparison with each other? If I try to define them for you, I will say CSR is collection of fluid at macula. But where in the macula? There are so many layers in the macula, in the retina. In. Anybody? Where does the fluid collect in CSR? Yes, very good. Subretinal space. Collection of fluid at the macula in the subretinal space. Yes or no? The space between neurosensory retina and pigment epithelium. Okay? Now, if the fluid is collecting in the subretinal space, the pathology, the damage, the defect must lie in which layer of the retina? Retinal pigment epithelium. Because the retinal pigment epithelium is damaged, that is why the outer blood retinal barrier is broken. So the choroidal blood vessels are sending their fluid into the subretinal space. Am I absolutely crystal clear about this, everybody? Yes? What about cystoid macular edema? Again, there is collection of fluid at macula, but in outer plexiform layer, OPL. If you remember, it is the sixth layer, everybody. INGIIO. Okay, everybody? INGIIO. Sixth layer, everybody. Am I clear to everybody? So sixth layer means, if you use your head a little more, sixth layer means that this is some kind of problem in the inner circulation. Yes or no? First 6 layers. But in subretinal space of RPE means there is damage to the outer circulation. Okay, everybody? Outer circulation damage somewhere in CSR, inner circulation in CME. Okay? Now, both these diseases are similar in the fact and dissimilar in which fact I have told you. Now, let's see what are the risk factors for each of these two conditions. Risk factors for CSR and risk factors for CME, guys. Okay? Risk factors for CSR. Number 1, everybody. Males 25 to 55 years of age. So we can relatively young males, we can say. Okay, everybody? Secondly, type A personality. Type A personality psychiatry, everybody. Patients who are workaholic, prone to stress. So stress is the keyword here, everybody. If I joke about it, I will say a lot of you can never have CSR. You don't take stress, do you? Do you guys? No, we don't usually. We are carefree people. Yes? Number 3. The third important risk factor is, everybody please remember, steroids. If a patient is taking steroids due to some disease, then steroids can lead to occurrence of CSR, or if the patient has Cushing syndrome. Okay? Not taking external steroids, but steroid level is increasing in the body. Yes? There should be no confusion about this. The fifth risk factor and unlikely risk factor is H. pylori infection. Okay? It has also been associated with the risk of CSR. Done? Please do remember these important risk factors. A lot of questions are based around this. Okay? Now, risk factors for CME. For the risk factors for CME, I will give you a mnemonic. The mnemonic goes like RUN, R-U-N, for pride. If you are a little healthy, just a easy way of saying fat. Run so that you get thin for your own pride, guys. Run for pride. Just a simple day-to-day mnemonic. Yes. R for retinitis pigmentosa, a condition of the retina itself we will discuss. U for uveitis, inflammation of uvea. N for the vitamin niacin or the addictive agent nicotine. Niacin question was recently asked in NEET exam. P for prostaglandin analogs. If we have paid attention to the side effects of latanoprost, prostaglandin F2 alpha analogs in glaucoma treatment, everybody, there we have written as the fourth side effect cystoid macular edema. Then R for RVO. RVO, if I put a C in front of it, CRVO, retinal vein occlusion. Again, we are going to study it. I for Irwin-Gass syndrome. If you have forgotten it, everybody, then please remember it is a cataract surgery complication. A triad of CME, bullous keratopathy and vitreous touch. D for diabetic retinopathy. And E for the drug epinephrine if administered to patients who have aphakia. Okay, everybody? Run for pride. 8 important risk factors. Again, a commonly asked topic in some way or the other. They use these risk factors as history or as direct questions, as I just pointed out to you about the niacin, which was recently asked in the NEET exam. Okay, everybody? Done? So just something which you need to remember, nothing to understand here as far as risk factors are concerned. Now, we know what is the disease. We know what are the risk factors for each of the following disease. Yes? Then let's see the presentation. Clinical features. If you understand, to a large extent, the clinical features in both the diseases will be same. Can I say so? Let's talk about the symptom first of all. There will be loss of central vision. Can I just write same? Both the diseases are getting affected at the macula. So in both cases, there will be loss of central vision. Secondly, there will be metamorphopsia. Again, this will be the same in both the cases. Why, everybody? What is metamorphopsia? Metamorphopsia is basically some distortion of vision, some change in the shape or size or form of image. Yes, metamorphogenesis. Metamorphopsia. The patient says, I see wavy lines on Amsler's grid. That is an example of metamorphopsia, but that again will be seen in both the cases. Symptomatically, both are the same. Then how do you differentiate, everybody? How do you differentiate? Let's say you look at the macula from your ophthalmoscope. Yes. In both the cases, you will be able to see a slight swelling. Because there is collection of fluid, there will be a slight swelling in both the cases. How do you differentiate? Okay. If you are saying OCT, because the layer of collection of fluid is different, you may be right. Yes, let's see. In OCT, what is the first thing you will see? Focus on the OCT that we had shown. The fovea normally appears like a depression, but now there is edema. So there will be loss of foveal depression. But won't this loss of foveal depression also occur in CME? You understand what I am trying to say? Yes? In chronic cases, okay, which have had some time to develop, that is where OCT will be able to differentiate. In OCT of CSR, because the fluid is collecting in subretinal space, think about it, everybody. The fluid in the subretinal space will push the neurosensory retina up. So there will be a shallow neurosensory retina detachment. Okay. But again, understand this will only be after some time. Yes. Similarly, there will be cystic spaces in outer plexiform layer. The name is cystoid edema. So cystic spaces will be seen. Yes. But this is only in chronic cases. What about a case which has presented to you before these OCT characteristic changes have developed? Can you do another investigation to differentiate between CSR and CME? Everybody, think hard, think hard. Can you do B-scan? Can you do FFA? Can you do FFA? FFA is for vascular as well as macular pathologies. Macula should normally be dark on FFA. Here, due to the fluid collection, along with the fluid, the dye will also collect. Yes? So, how to differentiate on FFA? On FFA, the pattern of leakage, or rather again I say pooling of dye is noted. Okay? In cases of CSR, either we say ink blot appearance, or the second appearance is smoke stack appearance. धुएं का बादल, smoke stack appearance, which is also sometimes called as umbrella appearance. Whereas, when we will see a case of cystoid macular edema, we see a flower petal appearance or petaloid appearance. So first of all, the easy part, you learn this, you remember these names. If a straight question, named question comes, you are able to answer this. Secondly, can you visualize it in a photograph? Yes, you can, guys.
So let's see the images, guys. Two images on your screen are visible here, A and B. If you are saying we have already seen the first image, A image, yes you have. Yes you have, everybody. When we were discussing the investigations, when we were discussing, everybody, FFA. Yes, I had actually shown you the first image. Now let us understand what is this image. You're already answering, I know. See, this is the optic disc. These are the blood vessels. These will be forming an arc in this side. That means this is my temporal side. That means this is my macula. My macula, which should normally be dark, has now leakage of dye. But what is the shape of the dye collection, everybody? That is what we want to see. We have just read the names, everybody. So can I say this looks like an umbrella, everybody? See? This is the cap of the umbrella. This is the handle of the umbrella. Or I can more or less make out that this looks like a mushroom or a smokestack. Yes? That means we are talking about smokestack or umbrella appearance. And that means this image is very clearly indicative of CSR. Now, let us see the B image, everybody. This is the image we are seeing for the first time, but this should be a ridiculously easy image. This is the optic disc. Very faintly we can see these are my blood vessels. This is the temporal side. Even if you can't see all that, everybody, let us just see this. What does it look like? Gende ka phool. Yes or no? It looks like a marigold flower, everybody. This is your flower petal appearance. Cannot be an easier image, everybody. That means it is diagnostic of cystoid macular edema. Okay? So that's what I always say. Once you remember the names, everybody, half of your job is done. Once you remember the names, you just have to see them in the photograph, everybody. But if I have this photograph and I don't know the name, then I cannot diagnose. It's the other way around, guys. I have always said we are worried about the images, but actually we should be worried about the theory first. Once we remember the theory, the images will themselves come. Ho jayega. But once we remember the images, no, there is nothing to remember in the images. So please focus on theory first. Yes? Now, let us see the images of OCT also. We said another investigation, OCT can be used to differentiate in chronic cases. Yes. So now let us see the images of OCT. Now, in OCT images also we have two sets of images, A and B. Let us see the A image. If we remember when we were discussing the investigations, we had said in OCT, let us look at the red line. Now this red line has been drawn with black color here, everybody. You can see the red, everybody. That means this is which part, everybody? RPE. What do we see? We see that RPE is still present, but in the central area here, there is collection of some fluid, due to which the neurosensory retina has been pushed up. So that means this photograph is showing us shallow neurosensory retina detachment. That means this is indicative of a long pending case of CSR. Yes. Compare this to the photograph B, everybody. In the second photograph, what do we see, everybody? We see again the red layer first of all, everybody. This is our retinal pigment epithelium. At the macula or the fovea, everybody, which must have been here, which should have been a central depression, everybody, but now there is no central depression. We see some edema. And importantly, what do we see? We see some cystic spaces. Cannot be easier than this. So many cystic spaces, everybody. Yes or no? Easily looking at a case of cystoid macular edema. Yes, this is how easy it is to diagnose, everybody. So again I say we need to be able to differentiate. We need to be able to differentiate because the symptoms are the same. We can differentiate either by OCT in chronic cases or by easily FFA. Without differentiation, everybody, on the investigations, you cannot proceed with the treatment here, everybody.
Now the question which begs importance is, why do we need to differentiate between CSR and CME when they are conditions which are similar in form of collection of fluid? Because obviously the treatment must be different. Okay? If I talk to you about the treatment of CME first, think about it. There is some fluid which is accumulating. Fluid is coming out of the blood vessels. So basically, can I say there is leakage from the blood vessels? Yes. Leakage of fluid from the blood vessels. Does it sound like the definition of inflammation? Yes. There is leakage of fluid along with cells and proteins. What do you do for inflammation? Leakage from the blood vessels. Does it sound like the definition of inflammation? Increased vascular permeability leading to leakage of fluid along with cells and proteins. Yes. So somewhere the kind of pathology is inflammatory. I'm not saying it's an inflammation, but somewhere the fundamental is the same. So for inflammatory process, can we give steroids? Yes. Steroids are the mainstay of treatment in cases of cystoid macular edema. There can be other things which can be done based on various causes, but steroids are the mainstay. Now, if I talk about CSR, the same thing is occurring in CSR. So I will like to give steroids in CSR, but can I give steroids in CSR? The big answer is no, because we already know that steroids are the risk factor, everybody, in CSR. So steroids should be contraindicated. You cannot do this blunder. If you give steroids in a case of CSR, instead the vision will decrease rapidly, everybody. Yes? Then you will say, oh, I gave you the wrong drug. Please stop this drug. Please stop this drug and don't do anything, because most cases are self-resolving. Most cases are self-resolving. Am I clear to everybody? You just have to remove the risk factor and they will resolve on their own. But if CSR is persistent for greater than 4 months, or if recurrence is occurring, or if visual field defect in other eye, that means the other eye is already at loss due to some other cause, maybe due to CSR only, I don't know. In that case, we say we can't risk our CSR to resolve by itself. We have to intervene. So how do we intervene, everybody? Again, think about it in simple terms. Think as if you are watering the plants at your home with a pipe. The pipe breaks. Yes, the water starts leaking. What do? You cover it with a polythene. You try to plug the leakage. That's what you need to do. So similarly, you need to plug the leakage in the blood vessel. Now, you can't tie a polythene on the blood vessel. How do you plug the leakage? You need to induce fibrosis. Fibrosis of the blood vessel wall, coagulation. Coagulation, yes. What will you do? Laser photocoagulation. Am I clear to everybody? If not laser photocoagulation, we have another treatment, everybody, which is called as PDT. Photodynamic therapy. Photodynamic therapy. Photodynamic therapy uses a drug which is called as vertetrax. porphin drug. Verteporfin consists of the porphyrin ring molecule, which is a photosensitizer. After we give verteporfin, you have to shine light of 689 nanometer for the drug to start acting. Yes, so this is a novel new technology called as PDT, photodynamic therapy. But this is only done if I have already stated, usually if it is a chronic condition greater than 3 to 4 months. Yes, that's it about the treatment of CSR. I hope you understand why these diseases are similar, because of their pathogenesis, because of their presentation, and that poses a challenge to be able to differentiate, and we differentiate because of the steroids. Steroids can be given in CME, they are the mainstay, but in CSR they are absolutely contraindicated. Right guys, done. I've shown you a lot of photographs of the FFA as well as in OCT. If you remember all those photographs, I hope you are done with CSR and CME, two easy conditions, macular disorders. Now, let's begin with the third macular pathology, everybody. ARMD. ARMD, full form, as all of us know, is age-related macular degeneration. This disease is less prevalent in the developing countries, more prevalent in the developed countries like the US of A. Yes? The fact that it is age-related tells us that the risk factor is old age, greater than 50 years. Plus, another important risk factor is smoking. I know even though a lot of smokers are there in our country also, but smoking is a lifestyle habit in the Western countries. Yes, so this adds to the risk factor, this adds to the incidence in Western countries. Plus, blue iris. In India, blue iris is Aishwarya Rai. So blue iris is very, very rare. But in the Western countries, lighter colored iris is much more common, guys. Along with that, high dietary fat intake. Okay? These are the important risk factors. A non-vegetarian primary diet in the Western countries is again fat intake, smoking, blue iris, everything is towards the Western countries. Okay, now, what is the classification or types of ARMD, everybody? So, broadly ARMD has been divided into two types. Dry ARMD, also known as non-exudative ARMD, and wet ARMD or exudative ARMD. I hope you understand the names yourself. Exudation means some kind of fluid, everybody, so that's why wet. Non-exudative, dry. Now, dry is further divided into three stages. Early dry, intermediate dry, or late dry. Dry can be divided further into three stages: early, intermediate, or late stage. Early and intermediate, both of them present with something known as drusen, and secondly, hyperpigmentation of retinal pigment epithelium. The late stage presents with geographic atrophy of retinal pigment epithelium. And the wet, everybody, wet stage presents with two signs which we will discuss: PED and CNV. Okay? So this is basically the names of the types as well as the signs in each group of stage. We are going to discuss some points here, that is drusen, geographic atrophy, PED, CNV. Okay, everybody? First of all, let's see what is a drusen. So a drusen is, everybody, an extracellular eosinophilic deposit between RPE and Bruch's membrane. If you understand, everybody, RPE is the outermost layer of the retina, whereas Bruch's membrane is the innermost layer of the choroid. So outside the retina, before the choroid, what is accumulating everybody? Some kind of extracellular large deposits, okay, known as drusen or drusen, okay. They are visible like this, everybody. All these yellowish deposits that you see scattered, they are all drusen. How do you know that below the retina, everybody? You will see that the retinal blood vessels are going over these yellowish deposits. That means this is actually below the retina. Am I clear to everybody? If it was in the retina, it would have covered the retinal blood vessels. Can you understand this, everybody? All the blood vessels are superimposing, are passing over the drusen. Am I clear to everybody? Done? No confusion? Now, we know what is drusen. We understand hyperpigmentation of RPE by the name itself. We understand geographic atrophy. Geographic atrophy means a large area of the RPE will become atrophied. Okay, everybody? Then, everybody, what we need to know is what is PED. PED is pigment epithelium detachment. Pigment epithelium detachment. Due to these large which are going, everybody, drusen, they will push the RPE up. Along with that, the Bruch's membrane is also not functioning properly, everybody. Yes? So all of this will push the pigment epithelium up, leading to pigment epithelial detachment. If you want to see a photograph, this is what a PED looks like, everybody. You will be able to see in this area, everybody, all the 10 layers of the retina along with the red layer, everybody. This is not the same as CSR. You understand the difference? Pigment epithelial detachment. NSR plus RPE pushed up. Can I say this? No confusion about this? There is no fluid collection in the subretinal space. You understand this from the red line. Yes? Now, moving back, everybody. CNV. What is CNV? Choroidal neovascularization. Choroidal neovascularization. Now, what is this and how does it develop? Everybody remember that this is developing in the wet stage. In the wet stage, CNV is developing because in the dry stage, everybody, already what has occurred? Geographic atrophy. Geographic atrophy means RPE is now damaged. So, the outer blood retinal barrier is damaged. Bruch's membrane is also malfunctioning. Due to the drusen, it is destroying the RPE as well as the Bruch's membrane. So, when Bruch's membrane and RPE both are damaged, the choroidal capillaries grow as tufts. Where will they grow, everybody? Do you understand? Again, everybody, this is my retina, let's say. This is my RPE. This is my Bruch's membrane. And here are the choroidal blood vessels. Due to the drusen, everybody, this is atrophied, this is also destroyed. So these choroidal capillaries, they are growing as tufts. Where will they grow, everybody? They will grow into the subretinal space. Yes? So, choroidal neovascularization. Okay? Am I clear to everybody? They grow into subretinal space, leading to hemorrhage. Neovessels are abnormal vessels. They don't have a stable structure, so they will hemorrhage. Subretinal hemorrhage. Now the hemorrhage will try to resolve. So what will occur, everybody? A fibrovascular complex will form. Yes, the blood is trying to get absorbed. A fibrovascular membrane has formed, everybody. This is known as CNVM, choroidal neovascular membrane. Choroidal neovascular membrane. This choroidal neovascular membrane, everybody, is of two types: occult CNVM and classical CNVM. Occult and classical, two names, not going into the details. Classical CNVM is formed in subretinal space. whereas occult CNVM is formed in sub-RPE space. What do you understand, everybody? Very easy. See, the main hemorrhage, everybody, is occurring in the subretinal space. I know. But because everything is now continuous, some of the hemorrhage is occurring here also. Yes? So, can I say this is subretinal space, but this is sub-RPE space? Okay? So, depending on the location of the membrane, we are calling it classical or occult. Now, why is this important, everybody? If I ask you what is the investigation of choice of classical CNVM, think about it. This is a vascular problem, vascular vessels seen by FFA. But if I talk to you about occult CNVM, it is also a vascular problem, but it is nearer to the choroid. So choroid, everybody, ICGA. Do you understand this, everybody? Yes. So investigation of choice depends on the type of CNVM because of the position of the CNVM. I hope we are clear about this. Choroidal neovascularization, right? Once we know this, everybody, let's move on to the treatment. Treatment of the dry stage and treatment of the wet stage. They are different. In dry stage, everybody, actually nothing is happening per se. Drusen or slight geographic atrophy, yes. The only treatment which has been postulated here is antioxidants by AREDS2 study. Okay. They said give vitamin C and E plus zinc, which is an antioxidant. Along with that, give copper to prevent zinc toxicity, plus give lutein and zeaxanthin. Lutein and zeaxanthin are carotenoids. Carotenoids, they are like beta carotene, naturally occurring forms of vitamin A or beta carotene. Okay, so this is a fixed dose combination, everybody, which is given to stop the progression of dry ARMD into wet ARMD. That's the only proven treatment we have. Okay, now let's consider the wet stage, everybody. In wet stage, what is the main sign that we just saw, everybody? Subretinal hemorrhage, everything. Choroidal neovessel. Neovessels are forming. That means the treatment has to be prevent neovessels. Neovessels form due to which factor in the body, everybody? VEGF. That means if I ask you what is the mainstay treatment of choice, answer should be without any doubt anti-VEGF drugs. Anti-VEGF drugs. Where should anti-VEGF drugs be given? Or how should they be given? Oral, intravitreal, topical? See, I've said the answer. I have again and again said when the problem is in the retina, the drugs need to be given intravitreally. So, intravitreal injection of anti-VEGF drugs need to be given. Now, if you know your pharmacology, you should already know the names. If not, then I'm just mentioning the names here. Bevacizumab, Ranibizumab, Aflibercept. Okay, these are the three drugs which you should know. And then there is a fourth drug which has been recently approved, everybody. Brolucizumab. This has been recently approved. Okay, everybody. Bevacizumab and Ranibizumab, both of them inhibit VEGF-A isoform. Okay. Aflibercept is a soluble decoy receptor. So it is a different mechanism, everybody. It is not inhibiting VEGF secretion as such, but it is forming decoy receptors. Yes. So the VEGF will come and act on those artificial receptors. So thus they will not be able to cause neovascularization. Brolucizumab is one of the smallest molecules ever made for administration. Done, everybody? No confusion? Second, everybody, the second treatment option that we have is PDT, photodynamic therapy. Photodynamic therapy, just like in CSR. And the third treatment option that we have is laser photocoagulation. laser photocoagulation. This is usually done if extrafoveal CNVM, which spare the fovea. They are affecting the macula but not specifically the fovea, everybody. Whereas anti-VEGF and PDT are preferred if subfoveal or juxtafoveal CNVM. Subfoveal means right beneath the fovea, juxtafoveal means just surrounding the fovea. Am I clear to everybody? Simple English, simple language, everybody. Please remember through the name, this is a very easy disease. D for dry, dry for the important sign, D for drusen. And the treatment is antioxidants. Wet, wet means blood, blood means neovascularization. Because neovascularization is due to VEGF, the treatment of choice is anti-VEGF drugs. Apart from the other points, this is the way you form a basic remembrance of your ARMD. These are the three main conditions which we recognize as macular pathologies, which we need to learn and answer as macular pathologies. Okay, everybody? Now, apart from these three main pathologies, there are some small conditions of macula or macular disorders that I can tell you. The first simple thing is, I am mentioning a name, epimacular membrane. From the name itself, it is very clear. Above the macula, epimacula, there is a membrane. Just remember, this is also known as cellophane maculopathy. It's like a cellophane sheet covering the macula. As simple as that, nothing else, everybody. Then another important condition that we need to know is called as angioid streaks. Angioid streaks. What are they? They are fine cracks in Bruch's membrane. Crisscross fine cracks in Bruch's membrane at the macula, everybody. Okay? What are the causes? The causes characteristically are remembered by a mnemonic, everybody. I hope you have read it. PEPSI. P-E-P-S-I, everybody. Okay? P for pseudo xanthoma elasticum. E for Ehlers-Danlos syndrome. P for Paget's disease. S for sickle cell disease. And I for I don't know. I don't know. In popular words, that is called as idiopathic. Let's make a fool out of the patient. When you don't know anything, say idiopathic. Right, guys? So, angioid streaks, 5 important causes remembered by the mnemonic PEPSI. Now, lastly, everybody, one condition that we want to discuss here is called as hypotony maculopathy. Hypotony maculopathy. Okay? Hypotony means IOP decreased, leading to some problem at the macula. Hypotony maculopathy. This develops when IOP goes less than 5 mmHg. Okay? Now, what are the causes? The causes are number 1, everybody. Excessive drainage after glaucoma surgery. I hope you understand this yourself. Let's say we are doing trabeculectomy. We are trying to increase the drainage of aqueous. But what if the drainage is more than required, everybody? Yes, leakage is occurring from the draining site. Secondly, everybody, retinal detachment, RD. Retinal detachment also leads to severely decreased pressure of eye. Okay. Thirdly, penetrating trauma. Should be very clear, penetrating trauma will lead to leakage of aqueous. Number 4, everybody, chronic uveitis. Chronic uveitis, as you would have seen or read in the uvea chapter, chronic uveitis leads to ciliary body malfunction. inflammation of uvea. So when ciliary body is malfunctioning, ciliary processes are not producing the aqueous enough, right guys? So that's your last cause, chronic uveitis. Am I clear? That's it about some of my small macular pathologies to go along with the main 3 diseases that we have read, CSR, CME and ARMD. I hope you have been able to understand the investigations, Amsler's rate, photo stress test and all the other names that we have said, because it is a macular function test. It is important for us to at least know a little bit about them and remember the names. 2 important diseases in comparison with each other, a lot of photographs, CSR, CME, a very easy condition, ARMD, more prevalent in Western countries, and some simple topics like hypotonic maculopathy. Right guys, that closes our second group of disorders, that was macular disorders. Now we will begin with the third group of disorders, everybody, dystrophies of the fundus.